Step into 2025 with The Toolkit, your interactive digital magazine packed with resources to empower your DPC practice. Discover articles on marketing, patient engagement, finding balance in your life, and tools to connect you with courses and more. Explore partners like Clearwater Benefits, offering health coverage for DPC doctors, families, and small businesses, including exclusive health share memberships. Learn from Aligned MD, using organic, ethical marketing to grow your practice while building patient trust. And Practice, a HIPAA-compliant system automating patient engagement across email, social media, and SMS. Learn more about Terra Health Coaching, helping you extend your lifestyle medicine care through personalized coaching. And FullScript is streamlining professional-grade supplements and now wholesale labs, supporting the amazing quality you bring to whole person care. And you can also learn more about Phasal Labs, bringing affordable on-site cardiac screenings directly to you, no matter where your DPC is, with as few as 10 patients. Head on over to mydpcstory.com/12 days of Christmas. That's the number 12 days of Christmas. Or check out the link in the show notes. This holiday season, let's grow the DPC movement together. The DPC Directory is here to connect businesses and mentors who understand direct primary care with direct primary care doctors and clinicians, making it easier than ever to find amazing partnerships. Sign up for a free account today and start exploring everything the DPC Directory has to offer. Let's make 2025 a year of connection, growth, and progress for the DPC community. Visit thedpcdirectory.com today to join in or check out the link in the show notes. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
I love doing family medicine, and I don't like an insurance interference. I don't like the fact that there's somebody between my patient and me telling me how to do my job, because I spend an awful lot of time trying to justify what I know how to do with people who sit behind computers and don't have a medical degree. I'm Dr. Bill Fisher of Innovative Medical Therapies, and this is my DPC story.
In 1991, Dr. Bill Fisher established Pekin Family Practice in Pekin, Illinois, with a vision to create a center for comprehensive patient health and wellness. Board certified in family medicine, Dr. Fisher's experience has expanded to include cosmetics, laser treatments, hormone balancing, weight loss, and more. Due to frustrations with insurance, in 2011, he opened the Cosmetic Skin Center of Central Illinois, which was launched to provide cosmetic and skincare services. Then, in 2016, the Cosmetic Skin Center became Innovative Medical Therapies, combining weight loss, hormone optimization, and laser therapies. And then, in 2019, at the age of 64, Dr. Fisher embraced the revolutionary direct primary care subscription membership model for healthcare services. Innovative Medical Therapies emerged as not only an affordable family medical practice, but a Midwest medical spa offering laser, aesthetic, weight loss, and health and wellness services under one roof. He continues practicing in his dream practice and looks to do so for as long as he is able, and is now also looking for a partner to join him on his DPC journey. Welcome to the podcast, everybody. Thank you so much for tuning in. I am so excited to be talking with Dr. Fisher today. But in case you did not know, we have dropped just a few days ago the Toolkit. It is a digital interactive magazine all about direct primary care. So I'm hoping that you can draw some inspiration and find resources that are available to you and accessible that can help make your DPC journey even more exciting in 2025. So with that, welcome to the podcast, Dr. Fisher. It's so great to chat with you again.
Thank you.
So, as you mentioned, it was amazing meeting you and your wife, Chris, at the DPC Summit in Dallas. And one of the things that I really loved talking with you about was that you opened after so many years in the insurance-driven world. And that is something that when I look at all of the guests that have been on my DPC story and I look at the responses that I've gotten from listeners, one of the things I get, especially for people who are further on in their careers, is I could never do that. I have been in this practice, whether it's a private practice or been an employee for too many years, the transition's not worth it. And so I really hope that through this conversation, people can, in whatever stage of DPC they're in, really get an understanding as to how did you pull from your experiences to say, I'm not dead yet. I am 64 and I'm going to do this, and not just continue on doing what you had always done. So with that said, walk us back to, you had your own private practice starting in 1991. Tell us about your transition, especially as a physician and an entrepreneur, that drove you to changing paths a couple of times, opening the Cosmetic Skin Center and then opening eventually in Innovative Medical Therapies.
Well, let me go back historically and tell you a little bit how I got to Pekin, which is near my home. I spent 8 years in the Army and did my residency in family medicine in the Army. And after I did my tour, my 8 years, I got out and went into private practice. And I came back to Central Illinois, which is home for me. And this is back in the early 90s when hospitals or practices were giving you income guarantees as a physician to come in and set up a practice. And at that time, I happened to be a family practice board certified that I did obstetrics. I did high risk obstetrics. And that was pretty high demand at the time to have a family practice doc was doing obstetrics. So we interviewed quite a few places and we finally ended up at Pekin, Illinois. And hard work and grace of God, we got where we did. And it went very well. In fact, within 2 years, I had to have somebody else help. I had a nurse practitioner, and then I had a physician assistant, and then I got another partner that came with me late in the 1990s, but he and I didn't see things eye to eye, and we parted ways, and I carried on from that point. The practice has never been a problem. Insurance got to be more and more of a problem because in the early 90s, they were just starting to do the CPT codes and all these things of how to get paid. And I just left the military where we got paid whether we saw one patient or whether we saw 50. So we got a monthly paycheck. There was never a fee for service. And so that was a whole new concept for me. But I found out, just like anybody else, it's in business for themselves. In our capitalist system, which has its flaws, but it's still a pretty good system, that if you work harder, you tend to make more money. Well, money wasn't the thing that drove me. I've enjoyed being a physician. And if I had thought about money, I probably would have gone into orthopedics or plastic surgery. So that was never really my goal. I just wanted to be a physician, and this allowed me to do it. So go back to the Pekin Family Practice. I got to the point I was working harder and harder, and in the 2010, 2012 range, it was like more and more patients doing inpatients, still doing obstetrics, and the payroll was going down. And I said, we got to do something different. So I started looking for other opportunities. And that's when I started doing the cosmetics, Botox, fillers. And I learned quickly that you quickly go from Botox to fillers. And then you have to, if you're really going to make the cosmetic thing go, then you start buying things like lasers. Well, you may or may not know, lasers are not cheap. And I started out with my first laser, which was used, quickly found out that didn't work, and then took the dye. Well, I started out with one laser. I think I now have 6 of them. So I do quite a bit of laser work for hair removal and skin tones and skin tightening and vaginal rejuvenation and spots, and you name it, I do with lasers. But that has just kept going. That has gone very well. That's just something I've been doing since 2012. As a family practice doc, whether it's the number 1 or number 2 cause of preventable illnesses, whether you have obesity as a diagnosis, well, I've tried to get people to smoke all my career, not just when I was in private practice, but I have worked very hard to get people to be healthy. And to me, I've always told them when I first introduced myself, it would be nicer to have you healthy and see you in a year's time for whatever physical exam or whatever needs to be updated, rather than to see you in 2 to 3 months, take care of your blood pressure, your diabetes, and all your chronic illnesses. So prevention has always been important to me with the family medicine part, and the weight loss just seemed to be a natural fit. So we started adding weight loss to it. And I searched for a weight loss program, and we've been very happy with the one that we selected, and I've continued to do so. Back up a little bit, in 1998, I decided to build an office, built a 12,000 square foot office. And about that time, people were starting to sell practices to the systems and hospitals and stuff like that. And here I went and built a 12,000 square foot office. And it was not easy to do that, but we made it happen. I learned the hard way in medicine, like anything else, you don't work on a handshake. Handshakes don't work. And I thought they did. And so that was a tough go because the guy who was going to do it with me decided he was going to do something better on his zone. And so now I was left with a whole 12,000 square foot building, and I had to scramble now to keep it up and running and going. And we managed, had some lean years, but we got through that. And about 2015, I said to my wife, I said, what are we going to do with this building? Because there's no cowboys or cowgirls coming out that want to go in private practice anymore. Everybody wants to work for the systems. And I said, at that time, I was 8 or 9 years younger. I said, we need to look about what we're going to do. One of my high school, a guy in high school with me was the CEO of one of the systems here, a big system, St. Francis in Peoria, which is a big medical system. He says, if you're interested, just let me know. And I thought, okay, fine. I can finish out my career with basically doing this and I'll be fine. Well, that didn't quite work out that way. The dating and the courting with OSF and myself, and I'll just say it because it was OSF and it was me, so it's not a rumor. The acquisition went well, but once I signed my name on the line, holy moly, things changed real quick from that point on. And so long story short, I worked 2 years of indentured servitude for one of the systems. They and I got along like oil and water. We did not do well. And at the end of my 2-year contract, I said, we're done. Thank you very much. And I'm going to go out and start all over again. Well, as everybody who's listening to this knows, to get paid in the insurance business, you have to be credentialed. And when you leave private practice, which I did in 2016, I left private practice and went to work for a system. They had to re-credential me with the insurance companies. And that was not a problem because it was just a drop in the bucket for a multi-million-dollar operation. But when I left the system, I had to re-credential again. Even though I didn't change, the insurance didn't change, the employer changed. So I went from private practice working for a corporation and then back into private practice. And that was a little bit of a challenge. So I had a system set up because my contract said I couldn't take any of my old employees. I couldn't keep my phone numbers. I couldn't do anything that had to do with my past because it was all belonged to them now. So I hired a guy to help me out do this. Well, that's a story we'll get into some other day. But long story short, a month before I was about to be done with my contract in September of 2018, he and I parted ways because I saw things were not going well. I wasn't going to make the same mistake I made 20 years earlier. So I remember when I came home and told Chris, I said, the whole thing just fell apart because I told this guy we're done. And she says, what are we going to do? And I did the famous line from Gone with the Wind. I said, we'll think about it tomorrow. And we got in a car and drove to Michigan to see an old residency friend of mine who was in private practice in Michigan. He says, and we got up to see him. And that weekend had already been arranged. It happened to be, he goes, have you ever heard of DPC? And I looked at him, I said, what's DPC? What are you talking about? I have no clue. And he told me all about it. I said, that's just exactly what I do. He goes, yeah, except that you don't do with insurance. I said, really? So that was how I got introduced to DPC in 2018. And from that point on, between multiple organizations and going to every conference I could find and go to, I quickly got all the information I could get on DPC. And here we are 6 years later, and I'm still here.
I love
there
it.
You have it.
I love it. One of the things that you mentioned is, and I'm pulling on your experience while you were employed by the larger system, when you said that things were like oil and water in those first 2 years within the contract, I would love if you could just give some examples of what you experienced, because I suspect that there are listeners out there who are like, he's just mentioning what I'm going through right now. And I just finished residency. Or I think about other guests who have shared. Dr. Kirsten Lynn, she said that the administrator at her system said that they didn't trust the doctors to be able to manage their own schedules. Like completely ridiculous stuff has happened to us as physicians. Love if you could share some of those examples for people to be able to reflect on, are things like that also happening to me wherever I'm at in my medical career?
I still had some leftover samples in the office. I had Metamucil. I think I had some Colace. I think I had some Tylenol. I had some patients. I used to hand the samples out from the drug reps frequently because try them, see how they do. And some people couldn't afford them. So I would make sure they still had drug samples if I could get them that way. Well, somebody had found out that I had drug samples that I was giving out, and that was not allowed. And I couldn't be doing that. We don't allow that to happen. Well, the samples I gave out, like I say, were Metamucil and I think Tylenol and something else, but that was a terrible crime. And then one of the other things was, since this was a Catholic system, I had used birth control pills. I don't remember what it was for. I think it was somebody who was having a teenager who was having a problem with heavy, frequent periods. And I put that, so I started on oral contraceptive. Well, you thought the world was going to end because I gave somebody a birth control pill. And this was a Catholic system. And I went back there and stood for another just up one side, down the other. And I said, whatever you guys want to do. I want to know who's the spy in my office. Oh, and then I was also told, you will not, if you find out who's telling this information, we will discipline you you severely. I was just the wrong guy to say that to. Just not the right thing to say. So when I left that meeting, that was my second meeting, and I called my wife, who says, do I still have a job? And I said, appears to be. And I called my attorney, and he says, let's come up with a plan how we're going to do this. So he and my wife got together and wrote this nice letter of how I was going to change all my evil ways and sent that to their attorney, and I got called back for one last meeting about a month later. Honestly, at that point, I figured I'd basically get the pink slip because nobody goes to the mother house, as we call it, and comes away without some kind of reprimand, relatively severely as if you're on the physician level. And I went to that meeting and listened to these people talk about, well, I can see Dr. Fisher has had a moment to reflect on basically the things we've talked about, and he's going to do this, and he's going to be a great asset to what we're doing here. And then when it got around to my turn, the same people, QR or quality improvement, HR, the vice president, my direct boss were all there. And they said, do you have something that you'd like to add? I said, yes, I do. When I can speak, let me know if it's my turn. I did that very sarcastically, by the way. And I said to the HR person, I said, you know what? I will do my job because I signed a contract that I was going to do this with you. But nowhere did I sign a contract that said I was basically going to bow down and do whatever you said I had to do because that was how you do things. That wasn't how this was presented, number one. Number two, I said to the quality improvement person, that's not how I take care of my patients. And I looked at my immediate supervisor and said, I will finish my contract and I will obligate and I will do everything I'm asked to do. I will follow all your marvelous rules. And I said, if there's any questions, I don't like what you've done to my practice. I don't like what you've done to my patients. And if there's no further questions, I'm leaving. I got up and walked out the door. I felt wonderful. And I came on and asked my wife, she said, how'd it go? I said, well, we'll see. I may not have a job now, but I basically said what was on my mind. And from that point on, they kind of left me alone. I don't know if it's good, bad, or otherwise, but they left me alone. I finished my obligation like I said I would. And then they started asking me towards the end. They said, well, what are you going to do with your practice? Where are you going? I said, listen, you guys wouldn't let me tell my patients what I'm doing. You wouldn't let me keep my phone number. You wouldn't let me do this. I'm not about to tell you where I'm going until Monday morning when I'm back in business again. Well, back in business again literally was right across the street. And the contract, as most of you people may know, if you're working for a system, you have a restrictive covenant. And if you're family practice, usually it's about 25 miles from wherever your present office is. If you're one of the specialties, if you're one to get to be a surgeon or something, they put 50 miles in those kind of guys. So when I turned in my resignation at the 90-day mark, the guy sat down, he talks to me, he says, you want a cup of coffee? I said, no. I said, this is going to be a relatively quick meeting. He says, well, what do you have in mind? Gave him my letter of resignation, said, effective this date per my contract, I will resign from this system and I will be gone. And he says, well, maybe you didn't understand that we have a restrictive covenant. And I said to the guy, I said, look, obviously you don't understand because if you had read my contract, you knew anything about it, you would realize in my contract, because I had an outstanding attorney, if you need one, let me know, I'll give you his name. But anyway, I do not have a restricted covenant. I can literally go across the street and start all over again. He says, but you have to be 25 miles from your office. I said, you didn't understand what I said. I can go across the street and start all over again, which is exactly what I'm going to do. He says, I've never heard of that before. I said, I had a good attorney. So there's my story about dealing with the previous employer. The employer and I didn't do well together. And that's where I came to the point I said, okay, what are we going to do now? And that's when I found out about direct primary care.
But you opened your clinic under the DPC flag when you were 64. You did not just say, yeah, DPC, that's cool, but it's not for me because I can't, I don't want to do anything different than insurance, even though you had not been happy with it. It was familiar. So once you heard about DPC and you were like, oh my gosh, this is amazing. I didn't even know that what I'm doing can be done without insurance. How did you solidify this is going to be what I'm going to do with my practice going forward?
Well, this was about 2017, 2018. And by that time, I think most of the people were involved with the system somewhere. There were very few independents anywhere. There were very few primary. I can't recall exactly, but less and less and less of the primary care docs that I had grown up with the area around here of the previous 20 plus years. Most of them have joined the systems because they didn't want to fight. It was, you have to pay this person, you have to be on this, and you have to get on the phone and justify your prior auths, and you have to talk to somebody. I remember one time I talked to a guy, I needed a CT scan for sinuses. And I got on the phone with this guy because I had to do a prior auth, I had to talk to this guy. And I said, first of all, let me ask you, what's your specialty? He says, I'm a cardiologist. I said, you're a cardiologist, and you're going to basically agree with me or disagree whether or not I can order a CT or a sinus series on a patient that's in my office in front of me that I'm listening to the complaint. He goes, well, yeah, that's what I'm supposed to do. I said, okay. Now, that never made a lot of sense to me. What is with all due respect to the cardiologist may or may not be listening, sinus CT or sinus x-ray is not really something a cardiologist needs to be working with or approving. The point is, I shouldn't have to. I'm wasting your time as a patient when I should be taking care of you, patient, not sitting on a phone, not taking the time to justify what I know how to do. Sorry, you got me stirred up there.
Well, it's I laugh because this is normal. That's what's so frustrating about it. It's so messed up that like you just have to laugh and be grateful that you're not playing in that game any more than you have to. Like absolutely, there are times when I have called the peer-to-peer and been like, this is the most ridiculous thing. I love though, I feel like I have mentioned this on the podcast before, and it's because it's one of my favorite visual examples, like Mr. Incredible sitting there saying, well, if you go to page to the little old lady and then telling her how to hack the system and it pissed the boss off. There have been some times where I've talked with peer-to-peers and they're like, I hate my job as much as you hate me doing this job. And so those are refreshing, but for the most
Right.
part, you don't get that conversation. And it is very frustrating when, it's you doing your job and somebody is putting that the wall between you and your patient and the job that needs to get done, in this case an image. So
Correct.
totally relatable. Totally relatable. When you were thinking about, hey, like if I didn't have to do billing and coding and the things that I used to do in private practice, how did your financial planning change? Because you didn't necessarily have to have the biller and the coder to do DPC.
I did a lot of talking. I remember, I think my first conference was with DPC was in Rosemont in Chicago, probably 7 years ago, that summer of before, in 17 or 18, one of the two. And I remember people saying, "You will, when you leave third party payment system, you're going to basically probably lose 85, 90% of your patients." And I went, whoa, wow, that's a chunk. But you also cut your expenses. Well, when I left, I sold my building. That was the one good thing. I will give credit to my system employer. They bought my building. So I did basically sell my 12,000 square foot office. I did very well, very grateful for that. And I also cut my employees from, I had 7 or 8 employees, full-time employees, and it was just me. And I now have 2 employees that work for me now. So I have a much smaller building there. I don't have a $10,000 a month mortgage. I don't remember what it was a chunk of money. I don't have a mortgage anymore. I do have to pay for the property that I rent, but it's nothing like what it was for the mortgage. So there, my expenses went down. And if you are in private practice, you realize that your employees are your greatest asset and they're also your biggest expense unless you've got a building you're paying for. So going from 8 employees down to 2 employees made a big difference on that as well. So I cut expenses doing that. And I just told people this is what I was going to do. I said, this is either what I'm going to do or I'm going to be done doing it, period, because I cannot survive in the business where I see more and more patients get paid less and less, and now have somebody tell me how to do I said, I can't do that, and I won't do that. And so I did everything I told them about direct primary care, told them how it worked. And I had a lot of the people that, honestly, I'm in a very blue collar community. And I hear these people up in, I'm downstate Illinois, down from Chicago. I hear people saying, well, I'm going to see Dr. Jones, or I'm going to see Dr. Smith, or I'm going to do whatever. They got these great practices. They're doing this DPC stuff and they're fighting who they can get in and see. I said, well, that's not the way it is down here in Central Illinois. If my employer doesn't pay for it, I'm not doing it. So I said, well, if you're not doing it, I'm not taking insurance. And so I guess we're not, it's the end of the line. I hate to do that, but I cannot survive doing that, because to do that again and start it all over again, that meant I'm going to have to have somebody does all the billing. Somebody's going to have to do fight with the people. Somebody's going to basically make sure somebody pays all this and all the things that go along with keeping the practice run. And I said, not doing that. It made a whole lot better. So you don't walk into your grocery store and say, send me a bill, and then have somebody fight that we're going to only give you 30 and 40% of what you're charging for that. Why are we doing that in medicine? There's something wrong with that.
Totally. And all of us in DPC totally understand that. What did you find was the most salient piece of information that you would hear from your patients who did make the transition to stay with you under DPC that really stuck with them?
I can give you 2 good examples. I've had Medicare patients that switch. So I do have some Medicare patients. Medicare Advantage. This past year, last year, I told my Medicare Advantage because, as you all know, Medicare Advantage just privatized Medicare with all the hassles of dealing with insurance. And I said, I can't keep seeing you guys. I'm sorry. I said, you got these options. You can do my direct primary care. You can pay cash if you want to, but I'm not going to do your Medicare Advantage. So I trimmed it even further just about a year ago now. No regrets. I have no regrets about it. And they either switched or they found somebody else. Some of them have come back and said, we hate the system. I said, told you. I warned you before you made that decision, but good luck. You want to get in and see somebody, have somebody be your advocate, the system is terrible to manipulate now. My goodness, I know how it works. I've been a patient, more than I'd like to say here recently, but I know how to make the system work. What are they with these people who have no clue? That's what our job as primary care physicians is, to make sure these people, our patients, get through this system and get the health care they need by the best person they can have it done with. And I find that hard. That doesn't happen very often anymore.
It makes me think about how I look back on my days at Creighton, and I really don't think that anybody really, taught us in terms of like part of the curriculum is to be an advocate for your patient. And I think that I saw people in primary care be advocates for their patients. And so I think that that's definitely part of how I picked up on to do your job holistically includes helping your patients understand their choices in the system where it's very difficult a lot of times because of amazing marketing strategies or the patient feeling like this is all there is. I don't have any other options. And so I think that I totally agree with you, though, when it comes to advocating for your patients is part of what we definitely do in primary care. Yeah, I mean, I see that pretty much every time I see a patient, as I'm sure you.
Correct.
Yeah.
Absolutely. That's why we're here. That's what we do as family practice and primary care physicians.
So when you were able to go down from 8 staff to 2, I want to take a moment there because, given that you have had the iterations of your medical career in private practice as an employee and then again in private practice, talk to us about the boss role when it comes to paring down your team from 8 to 2 people. Do you have any advice for people who are looking to do the same, whether it be because they're transitioning from fee-for-service down to DPC and they no longer need certain jobs done, or whether that be because a transition just needs to happen? Stay with us. We'll be right back. This holiday season, give your patients the gift of personalized whole person care with FullScript. Here at Big Trees MD, FullScript has made it simple to prescribe medical-grade supplements. Provide easy-to-understand education and offer wholesale lab pricing with integrated testing all in one platform. And with data showing that patients using FullScript are 70% more likely to follow up, FullScript shows the true spirit of ongoing care. Create a free account today and streamline your care with FullScript's trusted tools, supplements, and labs. Visit fullscript.com/mydpc today to get started. That's fullscript.com/mydpc or check out the link in the show notes. As a healthcare professional, I've seen the impact lifestyle medicine can have, not just in the exam room, but in patients' daily lives. And that's where Terra Health Coaching shines. They partner with practices to elevate care through the 6 pillars of lifestyle medicine: nutrition, physical activity, stress management, positive relationships, sleep, and substance management. Terra educates patients more about the why behind sustainable health, integrating personalized, actionable goals into your patient's routines, and they help motivate your patient to stay committed even through challenges. By complementing the care we deliver already by supporting individuals with the tools to sustain wellness beyond prescriptions is a win-win for everybody. So partner with Terra Health Coaching today to offer patients a deeper level of support that reinforces the care that you provide. Visit terrahealthcoaching.com today to learn more.
My wife and I did all our hiring, and the few times we had to fire people, I unfortunately had that position I got to do. Not a pleasant thing. But when I left the system, I made sure that my employees had a job when they left. They either stayed with that system or they had somewhere else they were going. I said, I just don't want you guys to be out here hanging. So I And I was very fortunate that was the case. Everyone of them had a job, or they went somewhere else, and they had a place to go. They weren't left without some kind of employment. So that was number one. But I had to start all over because part of the contract with the system was they said I could not take any of my old employees. That was very clearly written in the contract. So my old employees weren't an option. So basically I had to sit down and find new employees. And that's when you run your own business, guess what? You're the chief cook and bottle washer. You get to do it. And it's not the end of the world. I mean, I look back now after 33 years in private practice and I go, wow, how did I do all that? But you just do it. I tell people when I do with weight loss, I said that I had a lady come in today. She says, I got 100 pounds to lose. How am I going to do it? I said, 1 pound at a time. So you just do one thing at a time. You add one thing on. If I need to do this, if I need to add that, if I need to have more time, if I need to change my appointments around, you're in charge of it. You don't have somebody else pulling your chain and telling you what you need to do when your patients need to be taken care of. So I was fortunate enough that one of my employees, the two employees I have right now, are both former employees from when I was working for the system. One of them went with the system, but she didn't like working for the system. First of all, they told her she had to drive an hour to get to her new job, and she didn't like that, but she needed the insurance, so she went. And the other one just said she disliked it. She just said, I'll just not do anything. So she just sat back and she didn't do anything. And when I found out that she was available, I called her up. I said, this is what I'm doing. Are you interested? And this is how it's going to be. Are you interested in doing this? And she goes, yes. So I got those two employees back, and then I found out that they were interested in doing it. So I rehired them. But I had already gone through two other employees that had no clue what they were getting into. And I mean, it's just those things happen. There's bumps in the road when you're in private practice, when you're your own boss. You just deal with those bumps. It's not earth shattering. It's not the end of the world. You just deal with it.
Now tell us about pricing, because with you having been in private practice under insurance previously, and then making the transition to not taking insurance for most of your patients under the DPC model, how did you determine pricing for your patients?
My wife and I spent quite a few hours researching all the DPC practices throughout the Midwest, and something similar where we were, how they did it, what age groups, how they broke them down. And we just basically put something together from there and decided, well, from this age group, we're going to do this age, we're going to do that. If you have family members, we're going to do this. And so we did. I remember hearing a long time ago, you've seen one DPC practice, you've seen one DPC practice. And that is definitely a fact. That's how I got my prices. And we basically just picked ones we liked, thought fit for what we were doing. And that's what we did.
And over the past 6 years, have you changed your prices at all?
No.
And one of the things I definitely wanted to ask, because when in your bio, as we mentioned, legacy and your DPC continuing as you practice, but also like right now you're actively looking for a partner to come join you. When it comes to pricing and a DPC or a person who wants to be a DPC doctor at your practice coming on, have you talked about with Chris or just thought about how do you present to a doctor, hey, like this is the option when it comes to the member pricing point? The example that I think about is the Fisher Clinic, where Dr. Brewer-Eberly came on. They had somebody transition the patients, onboard them basically as Dr. Eberly was finishing residency, and then he came on. But he was under the understanding that there was like, this is what it is. This is the price that the membership is. Have you thought about change in price if the DPC doctor wanted that? Or would you really look to, hey, this is really working well for our community, so I'm really passionate about keeping this particular structure in place for memberships?
I like to think I'm open enough to entertain ideas. I don't have the end-all answers for everything. I've made lots of mistakes when I was in private practice, obviously when I dealt with the system, and still make mistakes, but you learn from your mistakes, hopefully, and go forward from that point and don't keep making the same mistakes over. So if I had somebody that was, when I came to town, I had an income guarantee, but that income guarantee was a salary, and basically for if I stayed in that community for 5 years, my debt was forgiven. I had financed my entire higher education on the government or something like that. I did time for money. I don't have a problem with that. And I think a lot of things that happen right now with physicians out in whatever system, wherever they are, is they do their quote utilization tour, and at the utilization tour, they say, this is not what I want to do. This is not how it was presented. Just kind of what happened to me with the original thing when I went to work for the system. That wasn't exactly how it was being presented at all. And so I found out that the amount of, this is going back 30 years. I remember our CEO at the time saying that every time you see a physician, you think that physician, the average physician brings in $1.9 million. And I'm sure somebody can out there correct me and that update it. $1.9 million is brought into the hospital because of that primary or that physician. That's average. That's psychiatrists, that's pediatricians, that's family practice, that's internists, that's surgeons, that's everybody. 1.9 million per year for the hospital. So the small pay that the hospital paid me at that time, after quite a few years, I realized like they didn't pay me squat because I made a whole lot more money for that hospital than I ever got credit for. And then when I was no longer basically getting a salary, I found out, oh, now I can make some money. Was like, wow, you work harder, you make more money. Isn't that amazing? So the new guys and girls that are coming out now, it's a little different system because there's nobody going out there saying, hey, we're going to pay your $300,000 or $400,000 medical school bill. Back 30 years ago, when I left the Army, I had a $130,000 debt, and that was a huge amount of money 35 years ago. Well, now they said, that's what I get to pay for a year for going to school and all my stuff. So that's like, wow, a chunk of money. And there are some people that are fortunate enough that they've done scholarships and they've done other things and they've had family or whatever. They don't have that debt. And that's great as well. But there are such things as loans. There are things that can help out. You can buy into practices slowly, stick around. When I originally started way back when, the idea, the model was you brought a new guy on and the guy was kind of like went out the other end. The old guy left and the new guy came in. I don't see why that can't work now with direct primary care, except it's not been around that long. So there are ways that can work. That's something that has to be discussed with whoever is looking to come on board, and somebody who is like myself that I will eventually say, yeah, I've done my time. It's time to do something different or whatever that might be. So there are options out there to help with the financial aspect of it.
And I think that really highlights that it's another way to highlight how DPC is different, because you're talking about the DPC being there no matter who is wearing the doctor hat in the practice. Right now it's you, but I think about how like other people have talked about how do you evaluate a practice? How do you sell your practice? But people like Dr. Doug Frago have sold his practice. There's people who have retired from DPC and have had a plan in place. And there's just like you've seen one DPC. If you've seen one practice handed over between physicians, you've seen one practice handed over between physicians. So I think it's really flexible and just really in the spirit of DPC, like this is a personalized possibility for another physician to come on and be part of the community in what way works for both of you. So I think that's great. Now, when it comes to, you mentioned earlier on how things just made sense, bringing on a branch of your practice that was focused on obesity medicine, bringing on lasers from 1 to 6. They're different services. I think I would love to hear more about how that financially helps you and your DPC, because when people are transitioning or when they're opening from 0 patients, that's a big question that people ask is how can I bring additional revenue streams while also bringing value to my practice and my patients. Stay with us. We'll be right back. Let's talk about Clearwater Benefits, the solution for DPC doctors, families, and small businesses seeking better health coverage. Clearwater Benefits brings expertise to the table, helping with the lift of the administrative burdens clinics may face while finding health benefits for their patients that complement their DPC memberships. Clearwater Benefits also helps put your DPC front and center in benefit conversations with potential new individuals and employer groups as their brokers work on your behalf to promote a combined total healthcare solution. Take the guesswork out of health benefits. Visit clearwaterbenefits.com today and discover coverage built with DPC in mind. For DPC clinics looking to expand their services without the burden of significant time, money, and resources, VasoLabs offers a hassle-free solution. Implementing new disease management programs can be complex and expensive, and many clinics worry about making costly investments that staff may resist. VasoLabs eliminates these concerns. They provide a complete turnkey solution, delivering an end-to-end cardiovascular disease management program. Through their cloud-based system, powerful dashboards, and streamlined administrative tools, they provide effortless integration. Clinics can be up and running in just weeks with no ultrasound expertise required. Vasolabs partners with practices every step of the way, ensuring a smooth implementation process as well. And with as few as 10 patients, clinics can bring in a Vasolabs tech to perform screenings, transforming the program into a revenue-generating service. Vasolabs simplifies cardiovascular screenings, making it easy for clinics to enhance care while minimizing effort and maximizing outcomes. Learn more about how Vasolabs can help you establish a cardiovascular screening program at vasolabs.com. That's VASOLABS.com today, or check out the link in the show notes.
In my case, I was already doing the cosmetics, and it just kept building. And so that was already there. The weight loss was something that was already in place. And as I've been to the different DPC summits, they've talked about having other things that you can basically and use and be a part of building your practice, as well as making an income while you're building a practice, the actual DPC practice. Now, so do you want to have 200 patients? Do you want to have 500 patients? Do you want to have 800 patients? The only thing is you start getting more and more patients, you're going to be spending more and more time. And more and more time. When I left the system I worked for the 6 months, I told her I had to get recredentialed. I didn't quite finish that story. So in the process of getting recredentialed, I started working ERs. I've worked ERs for my entire career. It wasn't a big deal to work ERs. I always tell the people I usually work critical access hospitals, small hospitals that maybe see in a 24-hour shift, you may see 10, you may say 15 patients. I've worked in bigger institutions where you work an 8-hour shift and you feel like you've been beat up because it's just nonstop. But I always tell them, and when in my town, I did that several times. I did that, and I said, just don't leave me here by myself. If you got a real emergency, there are people who train in emergency. Let those guys do it. But when you're working these critical access hospitals, you have to do it. So I've done all the courses. I've done ATLS, PALS, ACLS, all those things you have to have. And honestly, I've just kept them going because quite honestly, I work 4 shifts. I work 3 24-hour shifts a month, and I get paid very nicely for that. And I don't have any of the headaches of dealing with employees. I don't have to worry about who gets paid. I don't have to work time off. I'm basically there as an independent contractor. So I have chosen to just continue to do that. And that adds to what I've done, what I do. And I keep the cosmetics and the weight loss, they're still going. So it all kind of blends in together with my practice. Like I say, one practice, you've seen one practice. They're all different.
Tell us about the makeup of your practice, because I think that's absolutely a great point to make in terms of numbers. Typically 600 to 800 patients is a full practice, full-time physician, but that's not necessarily what everybody wants to do. And so you've talked about how you've diversified ways to streamline your income and support your DPC, and also practice the way you want to practice and use skills that you were trained in. When it comes to the makeup of your practice, tell us about the demographics.
I probably have I'm guessing after I let my Medicare Advantage patients when they left, and then some have come back, there are probably 400 Medicare patients that I still take care of. As I said, I didn't bring new people in. If they aged in, I just kept them. And my old ones, I wasn't going to let go. In fact, I have some that I just see for nothing because I figure if they're still around after this time, I just see them, take care of them. I don't worry about it. So that's probably about 400 patients, maybe 400, 500 patients. And I don't see those people very often, but they're part of the practice, and they take up, like any other time with Medicare. You're dealing with Medicare, they're going to take more time. I have some of them that were Medicare Advantage that said it was cheaper for to be DPC and do Medicare, and therefore they stayed because then they knew who they were going to stick. They knew I'm a known entity. They didn't have to go out and find somebody. So that was a big factor for some of my Medicare Advantage patients. Otherwise, I have a lot of what I had before, newborns that come in, not many. I found out in private, when I was in practice before, when you do OB, you keep your practice young. And when you stop doing OB, your practice gets older. I just, an interesting sidebar, I had to have my snowblower fixed because we have snow here in Illinois. And so I went and had it fixed. Well, I had the kid that fixed it, I delivered 19 years ago. So it was just kind of neat that here's somebody that I've known this family since I delivered all 4 of her kids, and I still see him. And now he's fixing my 2-cycle engines because I don't know how to do that stuff. that's just one of the fun things about it. So I've watched this family grow. I have new young ones come in. There are people in the area that are familiar with direct primary care. Samaritan Ministries is based here in Peoria, Illinois, Central Illinois. And for those that are interested in faith-based major medical type of things, but so they're right here, and so a lot of these people are familiar with that, and they've gotten my name from other people who are in those programs that say Fisher does this, contact him. So I have less little kids. I don't do obstetrics, so there's less kids. So it's more of teenagers and young kids as they're coming up, because everybody thinks right now you still have to go see a pediatrician. If I delivered to kids, they stayed there. But if you're not delivering the kids, they're just that's where mom took my brother. That's where they went to, and so they had to go somewhere else. I haven't made a big push to try to get to those back. If I was younger, I probably would. I'd say, what am I going to do about get these kids back in? Start talking about families and get the families in and get the whole family. You just have to stop and think about it. You have to think about how you're going to do it. You have to kind of plan it out. And I am not a great planner, in case anybody thinks I am. I am not a great planner. And my wife is definitely agreeing with that. So otherwise, it's 20, 30, 40, 50, 60-year-olds. Yeah, they're all in there. And most of them are people who either don't have insurance or don't have any other way of taking care, or they have huge deductibles. The Affordable Care Act made that very possible. They said back when that started, they used to pay $400 or $500. Now I'm paying $2,000, $3,000. And those people went, holy cow. And always a question about whether can I use my HSA and HMA and all those different things. Some people say some states allowed, some states don't. Some people don't know. I've checked with attorneys, and it's one of those things that I usually don't ask how they do it because basically they're paying me cash. And so their finances, how they deal with it, is up to them. What do I do in my practice? I do full service family practice. I do all my the usual physical exams, whether it's kids or whether it's GYN stuff or whether it's just wellness exams. I do vasectomies. I do my own lump and bump surgery. I do my own laceration repair, cryotherapy. I put in IUDs. I take them out. I do endometrial biopsies. You name it, I probably have done it or still do it. That's just how I was trained when I was trained 30 plus years ago. The other thing I do is I'm an aeromedical examiner for the FAA. And this is another thing that goes along with cash. These guys are pilots. They want to be flying. They don't want to be sick. They don't want to give any grief. They just want to get their medical done and get back in the cockpit. And by the way, those are all cash paying patients. They don't think that's not insurance. They walk in and write you a check or pay cash. So everything other than the Medicare patients I have are all cash paying patients, whether it's DPC, small percentage of cash patients I do have, or whether it's the other things that we've talked about, the cosmetics, whether it's the flight physicals or whatever. So it's all part of it.
How is the patient experience and your interaction with them different now because you do DPC and not a fee-for-service insurance based with all of your patients? Stay with us. We'll be right back. Let's take a moment to talk about AlignedMD, a healthcare marketing agency for direct primary care doctors. Built on the experience of running a private dental and orthodontics practice, AlignedMD knows it's not about pushy ads or gimmicks. It's about building trust and lasting relationships with your patients. That's where AlignedMD shines by specializing in organic, ethical marketing strategies designed just for you. If you're ready to elevate your patient connections and reputation, visit alignedmd.agency. That's alignedmd.agency today. Build trust, grow authentically, and stand out in 2025. Practice is the all-in-one patient engagement platform designed to simplify your practice. With Practice, you can seamlessly combine email, social media, website forums, and SMS, all on a HIPAA-compliant system that automates engagement for you. Never lose a prospect again, as Practice keeps your patients connected and informed without adding to your workload. Whether it's appointment reminders, follow-ups, or staying top of mind, Practice makes it effortless. Get ready to streamline your communication and grow your practice by visiting practice.com today. That's practos.com today, and see how automation can work for you.
I think the biggest thing I could say is I give you an example of 2 days ago. I had a patient came in with chest pain. And by the time I got to doing the EKG, the history, the physical, the stuff, made all the arrangements, called the cardiologist and did all this stuff, I'm looking at an hour's worth of time. I made all those arrangements. I made the phone calls. I made the contacts. Let's get this done. Let's get you in the system. Let's get this plugged in, make this happen. That he saw the cardiologist that afternoon. The cardiologist saw him and admitted him the next day. They did all this kind of stuff and it all got done. And when I was doing that for the system, I didn't have that kind of time. As soon as I entered the stuff and quote did the order in the computer, I lost it. It's gone. Push the button, sent. So I have the time with the people. I can spend the time with them. I said 30-minute appointments. I tell the girls I have a couple of people, and everybody that's listening probably has patients that 30-minute or the 15-minute appointment is always going to be 30 minutes because they're going to bring in a laundry list. And so they know those people. They've been around, so we know if Mary Sue comes in, she's gonna spend 45 minutes. We sort of spend longer time with them.
It's so funny because somebody was making a comment about AI scribes, and I use an AI scribe, but somebody was asking like, why do you need an AI scribe if you don't see 30 patients in a day? And I'm like, because my patient visits can be up to 2 hours long. And that's a lot of stuff to remember. Oh yeah, I said this, and oh yeah, I said that. So it is a different journey as to why a person could benefit from having an AI scribe. But I definitely hear you when it's so interesting to easily transition though. I think, and that's what's awesome about it, is because we went to medical school and we learned. My time at Creighton was very much like, all right, now we're going to do the heart exam. And then it was like, that's all we're doing today. And it was very like slowly getting you your history and physical skills. And you were never rushed. Like I never felt rushed. And so when I felt uncomfortable being rushed in fee for service, it was very, very natural for me to just feel at ease with more time with patients and not to feel like, oh, I can't spend any more than because that's not allowed. Who determines that's not allowed? You do now. So it's really cool. But I laughed at when you said this experience has, there's so many ways that guests on this podcast have shared how having more time with patients makes such an incredible difference for their quality of care, but also for your sanity.
Absolutely. And I do have a computer system for EMR, but I choose to write. I'm old. I like a chart in front of me. I like to write it down. I like to see it. I still do that. I will do that till I'm done. People want to do it with a AI scribe, or they want to do it with I've had a scribe when I was seeing 30, 32 patients a day. I had a scribe with me, worked out very well. And also that was an employee I was paying. But, if you're not on a 10 and 15-minute appointment, you can take 30 minutes and you can take a few minutes and write a note out and get an adequate note in there. And if you need more time, you can adjust your time to how you do it. I'm in control, as much of the control as I can have. I'm in control of my schedule. If I want to take next Friday off, I call them and say, how many people do I have next Friday? Can we move this one here? Can I see that one there? Can we have that one coming in there? And I make the decision. When I worked in the system, I had to call and ask for permission if I could take a vacation. I had to give them 6 weeks notice. I said, what do you mean what do you mean I have to ask for permission? I just do it. I'm the boss. I like that. Physicians, for most part, who was it that said, it was back in the 90s, somebody said organizing physicians is like herding cats. Well, golly Moses, we didn't get where we are basically by being told what to do. We learned what we did, busted our rear ends, hard work, went to medical school, did the residencies. We're obviously self-driven to do what we're doing, or we wouldn't be there. I don't care if you're an attorney. I don't care if you're any one of these professions where you put a lot of extra training in it. And to be told by somebody that's lesser trained than we are is difficult to swallow. And that's just kind of me. I have a hard time with that. If I offend anybody, my apologies.
I've shared this on the podcast, but it totally stings. And it's not even me, but it is me in terms of I'm connected to my husband. But when he was replaced with a non-physician model, I'm like, you've got to be kidding me. Nobody ever put that as in the future, potentially, like you don't even need physicians. You don't need to value the expertise level that we have spending 15,000 hours in training to be able to practice after we graduate residency. So the sting of that definitely is very relatable to a lot of people. When you look back on your DPC journey so far, what would you say to your younger self to help inspire anybody, including the people who are further on in their medical journey, to really consider DPC?
That's really waxing philosophical, Mariel. So let's say that if I were a younger Dr. Fisher, I wish I'd have known about this sooner. I wish somebody would have told me this was a way to do it, because as I said, when I left the Army 33 years ago now, that wasn't an option. This didn't exist. It was fee for service, and you get 90-10, 80-20, and it was a good deal. But that's not what it is anymore. And that has all gone away. And our businesses are being threatened by multiple different things. AI, you're talking about. I hope that I'm dead and gone before I have a robot walks in the room and does, unless it's like something from Star Trek. Might be different then. I don't know. Hologram, whatever. But I don't think we're at that point yet. So I wish I would have known about this sooner, because I would have done this long ago and not done fee for service, not with the insurance companies. That's what I would do different there. What as a person that's my age, and like I say, I started looking at this when I was 64. I'm 70 now. Yeah, you can do it. If you've done medicine this long, you can certainly do this. There's no reason not to. It just depends whether you want to take the time and the effort and the go. How long do you plan on doing this? If you're just looking for something to hang on for a year or two, yeah, that might be a little bit rough go. I don't know. It doesn't just happen overnight. You don't just snap your fingers and all of a sudden the place is flying. You got to get out and got to work it. And some people don't want to do that. I'd never promise that. Probably some of one of the best things that I have around where I am are small businesses. I mean, there's a lot of contractors around here and trucking companies and insulation companies. They've got 5 or 6 employees, and they can't get employees because they don't offer health benefits, because health benefits are outrageously expensive. So I'm going out and talk to these groups, and I'll talk to them and say, here's what I can do, and this is the price we charge for it. And they go like, that's what you're charging? Because we have a corporate charge that we charge to companies that come in and say they're going to build their whole company's going to come. And they said, that's it? I said, yeah, sorry, is that too much? They said, no, absolutely not. But it was, these smaller companies love it because they can't get good employees and keep employees because a lot of people work to have health benefits. That's sad, but it's the state of the economy we work in. You have to have something, and so this gives a small employer a chance to say, "Hey, yeah, we do. This is what we do with direct primary care guy, Dr. Fisher. You go see him. You don't send him to the emergency room if they get a sprained ankle. What do these guys do? They send him to the emergency room. Well, that's a $2,000 bill just walking in the door there. And so they walk into my office for what their monthly fee is, where they walk in once a day, once a week, once a day, once a year. It's still that monthly fee, and they go, holy cow. And their health expenses really go down. Those people love it. So they're out there, but you got to go get them. They're not going to come drop in on your doorstep because they're not familiar with this. In my part of the world, they're not anyway. And there are other parts that might be different, but around here, I've got to make myself known. And I've done that. I don't have a problem doing that. If you have a problem doing that, maybe you should figure out how to get that problem and go out and do it, because that's part of what it's going to take. You're going to have to work it. It isn't going to just come on natural.
And I will say that when there's DPCs now in all 50 states, it's pretty amazing to think that each and every time a DPC opens and has patients, it's helping break down what is DPC, and it helps break down and it helps put more word of mouth out there in the community and the ether in general to other people, so other people can learn about what we do as DPC physicians.
Agreed.
I am so excited to continue the conversation over in our Patreon community. So be sure to join us there. We're going to be talking about this 12,000 square foot building, retirement plans, and also how to incorporate aesthetics and lasers into your practice from the business perspective. Again, thank you so much, Dr. Fisher.
Thank you, Mariel. Have a good day.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.